Good afternoon, everyone, and welcome back to our last class. I'm going to start a few minutes early because I'm concerned that I might run out of time otherwise. So I'll take advantage of the fact that I think most of you who are coming are already here in the room today. So we'll continue with our unit on mental illness and therapy. I noticed today that something wasn't quite right when I was going through my lecture slides. I thought, why didn't I talk about depression or anxiety? Where was that content? I looked into it and I realized that I made a mistake when I was putting together this year's syllabus. And I accidentally and inadvertently dropped 3 modules of readings on Introduction to Psychological Disorders, on anxiety-related disorders, and on depressive and bipolar disorders. So I apologize for that. However, I think you've done enough readings in this class, and so you're not responsible for reading those modules in the textbook. However, I have added key content to this lecture. I wouldn't feel right if you left an intro to psychology class never having talked about depression or anxiety. So what is a psychological disorder? Last class, I was sort of critiquing this, the idea that we know what a disorder is. Well, do we know what order is? We're missing the first part, which is the actual definition. So according to the American Psychological Association, a psychological disorder refers to a clinically significant disturbance in an individual's cognition, emotion, regulation, or behavior. Now, give me a moment while I move this over, and I'm going to check the chat to see if everything's okay. Everything's okay. Good. Okay. So a psychological disorder refers to a clinically significant disturbance in someone's cognition, emotion regulation, or behavior. What does clinically significant mean? Clinically significant. It's normal to be sad. It's normal to have hallucinations now and then. Right? It's normal to be dissociated. Welcome. Yes, Alex.
Like a significant, I forget what the term is in statistics, but you're beyond the margin of error for what's expected.
I see the relation. So you're thinking about statistical significance. That's really about detecting whether an effect is reliable versus, can it be attributed to chance, because there's fluctuation due to chance. But
it's something.
I think you're onto the idea that it's kind of big enough to matter.
Like it's beyond the margin of error of, like, I might be more generally sad than, say, that person, but I also may be more generally happy, but it's still within that healthy.
Within a healthy range.
It doesn't affect our lives.
I see what you're saying. Yeah, the idea of a clinically significant disturbance means that it's pretty big. Welcome. It's big enough to be hurting yourself in ways that matter. It's big enough to be harming others. I mean, there's lots of things you do in the course of the day that hurt yourself. Anytime you drink more wine than you should, or go to bed late, or don't eat your vegetables, or say something nasty to your partner, right? You cause a lot of harm every day. Harm yourself a lot every day. Clinically significant is like at the point that maybe, you're losing your job, right? You aren't getting things done. Maybe your relationships are ending and you can't seem to get a stable relationship. So it's normal to be sad. Some of us are, higher baseline sad. We're the sad baby or the cranky baby. But, depression means that the person's life is like seriously impaired by this. Maybe you're staying in bed all day, right? You don't see your friends anymore, stop going to work. These disturbed or dysfunctional thoughts, emotions, or behaviors need to be maladaptive. Remember what adaptive means, right? Shown you this slide many times. So if something is adaptive, it gets you the result that you want. We call that success. If it involves navigating a hurdle, then we call that resilience. Welcome. I started a little early. So being adaptable is about using your resources in ways that get you what you want. Okay, so your behaviors are adaptive. Maladaptive is the opposite of that. Maybe it means that you are misusing resources. Maybe, but people do that when they have like an alcohol use disorder. It's okay to have a glass of wine, but having a whole bottle would be misusing that resource. And maybe they're responding in ways that hurt themselves or others. Okay, so ultimately their behavior isn't leading to successful results. But keep in mind that what we consider success depends on context. There's some system in which somebody, maybe somebody with more authority, says that's successful behavior and that's unsuccessful behavior. And in fact, this is so much of a problem that will institutionalize you or put you in a hospital or jail for doing it. Okay, so somebody is judging that as successful, and it's more than just you. So let's say that somebody is behaving maladaptively. Okay, now what are you going to do about it? Done a lot of different things in the past to address mental illness. Where mental health is basically being able to cope with life, contribute productively, and cope with the normal stresses of life. So what do you think the problem is with this person with the mental disorder determines the solution that you use. What you think the cause is informs the treatment. So if you think that the mental illness, the maladaptive, dysfunctional behavior is caused by an evil spirit, then you're going to have to try to get the evil spirit out. And this is a skull, an ancient skull with holes in it, and it's speculated that it's called trephining, that maybe what people are trying to do is make some hole in the skull so to let the evil spirits out. Speculative, we can't talk to that guy. Towns used to, in the Middle Ages, towns had towers where they put people with serious mental illness. I think they were called Fool's Towers. Then at one time there was a use of straitjackets. What does that say? I don't know if they still use those. Maybe the person's acting out, they might harm themselves or others, so tie them up. Nowadays, they would do this chemically, right? They would probably give a person a sedative. But then we've had other ways of managing. In ancient Greece and Rome, there were these women who went into trances. They had visions. They said very cryptic things like, beware the Ides of March. And they weren't seen as mentally ill. They were the soothsayers. They were the oracles. You wouldn't make an important decision without consulting the oracle. And the oracles were priestesses of Apollo. And there were some of the most powerful women in the ancient world. There's different ways that we've coped with the same issue historically, based on different assumptions. John of Patmos had visions when he lived on the island of Patmos. And he heard voices, heard things that other people can hear. He had visions, and he wrote down what he saw and heard. And you can go read it. Many people have. It has horsemen in it, and there's beasts and angels and lamps and prophecies. It's kind of hard to follow. It's called the Book of Revelations. People take it very seriously. Many religious figures would meet criteria for a delusional disorder of some kind if you did not believe that they were really having a divine encounter. If you took a totally scientific materialist perspective. So let's say you're not a Mormon, you're not a member of the Church of Latter-day Saints, okay? Then you probably don't believe that Joseph Smith Jr. encountered the angel Moroni and was given golden plates that he could read through his hat with the assistance of a clear stone in the bottom of the hat. Okay, but there's many people, many sane, productive, good people who wouldn't agree that that was anything else but a divine encounter. There were really tablets that he read through the hat. But why am I telling you this? It underscores that there is a heavy element of social construction behind what we call a mental illness, because it's about what's adaptive, right? Because it's about what's normal. And we can have, those are subjective concepts at the end of the day. Okay, and different people will call the same kind of bundle of symptoms different things. Okay, some people would say he's delusional. Okay, some people would say that's a leader. Until the 1970s, homosexuality was a diagnosable mental disorder. Where a friend of mine who's a psychiatric nurse was telling me about her time when she was working. She's retired now, and I asked her, what she found memorable from working at that psychiatric hospital up in Cape Breton, and she told me about a very, very depressed man. He was so depressed, and she was describing his symptoms. I said, well, what had caused that? Well, he was gay. Back then, that was a mental illness. And what would he be thinking? He's thinking, I can't change this. Everyone knows I've let down my family. Well, I think he's a bad person. There's still discrimination, there's still stigma, but it's not like that today, at least. But, back in the 60s, it was a mental illness in the official book of mental illnesses. That book that has the rules that decide whether something's a disorder or not. And there's only certain people that are allowed to use the book in order to make the diagnosis, right? But now it isn't. Not here, but there are other countries today now where it is still medicalized or criminalized. It wasn't seen as a problem in the classical world. Right? Neither was pederasty. That's like when an older person has a relationship with a teenager. That would be illegal today. Right? We call that a mental illness now. Okay, that's Sappho on the island of Lesbos, who's considered one of the great poets of ancient Greece. And you can see her influence in the word lesbian. There is cultural variation in modern mental illnesses as we measure them today, and still pick up cultural variation. The most universal ones are depression and schizophrenia. Anorexia as an eating disorder is more universal than you think. But there are other disorders that are more culturally specific. Like certain eating disorders are more common in the West. In the Far East, they have a mental illness that we don't seem to have here. It's called karoshi, overwork death. You work so hard that you die. And there's a phenomenon where people commit suicide through this. I've never heard of that happen. So people do, can overwork themselves and maybe develop some health issues. It's like that way more of an issue in Japan, where they have a culture that's more about the community and less individualistic. Right? For the first suicide missions, they had so many volunteers, they had to put like extra people in the cockpit. Harder to do that. Okay, so there's something about people's behavior that reflects the culture that they're in and the expectations and the norms of that culture. We can look at mental illness through a medical model or a psychological model, or even use both at the same time. I think we should also use a sociological model. It's not in your text, but that's kind of what I was getting at, this idea of how we thought about mental illness differently over different periods of time. This came about as a result of a social phenomenon at the time. Okay, so the medical model is the concept that diseases or disorders have physical causes. And then you can diagnose and treat and cure that illness physically through treatment, maybe in a hospital. Back in the day, people used to be a lot more concerned about sex. And that was partially because of STDs. Syphilis was the great pox, and it was known to be associated with sex and with madness. It was the subject of mystery and fear and taboos. Okay? The Turks called it the Christian disease. In India, the Hindus and the Muslims named the disease after each other. So this comes with a lot of kind of shame and judgment and stigma already. People are pretty scared of getting syphilis. It had something to do with sex. And so morals, right? As syphilis advances untreated, it infects the brain. And it leads to psychiatric symptoms, delusions, dementia, mania, depression, pretty much the whole basket, depending where the virus is in your brain. Okay. In 1905, the bacterium that causes syphilis was identified and isolated. And soon after that, they developed the treatment. And that, I think it's a penicillin, and that impressed us with the idea that mental disorders have a physical origin that's treatable. Okay, that's the history of that lens of looking at psychological disorder. So let's think about, what depressive disorders might look like through a medical model. Well, so what's depression? You know what it is generally. The person has very low energy, very low affect. There's a couple of different forms of it. Some people have a seasonal pattern of depression. Then there's major depression. Some people are chronically mildly depressed. But there's no blood test for depression. There's no blood test for ADHD. What we do is we see a constellation of behaviors. We call those symptoms. And in order to classify, in order to label, in order to diagnose the person as having this disorder, they have to meet certain criteria. And these criteria were established by the authorities based on their research. And now they're in this big book of mental illnesses. So what does it say? The individual must be experiencing 5 or more symptoms during the same 2-week period, and at least one of them has to be either depressed mood or loss of interest. There are 8 different descriptions here. So there's more than one way of satisfying those criteria. There's more than one way this could show up. There's more than one permutation. And so when we say somebody has depression or somebody has schizophrenia, there's going to be quite a lot of variance in what that looks like for that particular person. So at the end of the day, it's a clinical judgment, and hopefully a good one. But often there's no biomarker. I mean, sometimes there is. Again, in the case of schizophrenia, we might be able to see that there are changes going on in somebody's brain. It's really about identifying behavior. And every thought or feeling comes with a biological event. Okay, there's a biological basis to all mental illness because there's a biological basis to every thought or feeling or action that you have. Some neurons are firing somewhere in some pattern in some part of your brain. Okay. Neurotransmitters are being released, maybe particular ones. And some hormones are being released. So I can say that mental disorders are socially constructed, but that doesn't mean they don't also have a biological basis. We're putting a label on certain behaviors, a constellation of behaviors. We say, yeah, that meets the criteria for depression. And then we would, if we go looking for it, observe something at a biological level. So here's a brain scan showing somebody in a depressed state versus a manic state. And you can see that there's less activation during depression, like a low energy state. When they have mania, okay, then you can see a lot more activation. When a person alternates between depression and mania, call it bipolar disorder. It used to be called manic depression. In the manic state, a person is hyperactive, they're wildly optimistic, maybe they think that if they jump off the roof, they can fly, and their judgment can be dangerously poor. It is much less common than major depression, but if it's more dysfunctional, it's a strong predictor of suicide, unfortunately. Some mental disorders seem to have more of a biological, no, I'm not going to say more of a biological basis, are more heritable than others. Any behavior that you engage in, even if it is because of social pressure, has a biological basis. But what I'm trying to say is that some of them are more heritable than others. Some of them have a more genetic base with regard to that particular constellation of behaviors. So you can see that heritability estimates are pretty high for bipolar disorders, really high for schizophrenia, but less so for anorexia. Still pretty high. That's still like higher than the heritability estimate for personality, but it's lower for major depressive disorder. That suggests that there's more of a situational component. Okay, there's a bigger effect of culture, society, environment. And generalized anxiety disorder has the lowest heritability component of these disorders. And anxiety is pretty, well, generalized anxiety is supposed to be situational, but it's assuming that the person is in general in an anxious state, but you're still talking about a person in a situation somewhere. So even if they're anxious at home and at work, that's still, a fairly small cohort. So anxiety is more socially, culturally, environmentally driven. If we assume that there's a biological cause, then we're going to want a biological treatment. And so there are medications to treat psychological disorders that you can get from your family doctor. Maybe with referral to a psychiatrist who's also a doctor. But psychologists are not doctors. A psychologist might have a role in helping somebody with adherence to treatment. And sometimes people don't comply with treatment, and that's an issue, and then they get sent to the psychologist. Medication is, strongly indicated for some mental disorders, right? Like bipolar disorder or schizophrenia. Could be dangerous if they're not on their medication. And then in other cases, people might make a choice to use a medication, and they might say it works for them or it doesn't work for them. I know people who sworn that antidepressants made all the difference in their lives. Other people who say it made no difference. Other people who will say they got really sick on some medication. Antidepressant medications, sorry, I'm losing my voice, function to increase activity. There was a study on rats where they gave different groups of rats different antidepressants and watched what they did. They put them in some kind of, I think, like a water maze situation, and a certain antidepressant made them more likely to try to climb out of the situation, and another antidepressant made them more likely to thrash around in the water. But basically, it's about increasing activity and giving you a bit more energy. Interesting that antidepressants come with a warning like that. What could be going on there? Why would an antidepressant increase the risk of suicide?
Kind of spitballing here, but is it similar to how like a painkiller doesn't take away the pain, it numbs it? Like the problem is still, like I have a broken bone, but I'm on a painkiller. I don't feel it,
or maybe you do,
but I can't walk. Is it something like that? Like I can't walk because of my broken leg, but I don't feel my broken leg. I don't feel depressed, but there's still something in the background
that
then
yes, I think that might work.
And now you don't have anything to pin it onto as well. Like if I just suddenly can't walk with no reason,
I think you're
that's a lot worse than.
I think you're on I think you might be saying what I'm going to say in different words, maybe. The antidepressant functions to increase energy, but the person is still going to have their depressed way of thinking, their depressed worldview, that this isn't worth it, and I'm a burden to others, and I should just go kill myself.
But now they have the energy.
Yeah, so now they have the energy to make the plan, to come through on the plan. Yes.
Yeah, we talked about that in biopsych. It was one of the reasons was that. One of the reasons was that the antidepressant don't start working right away. So as well as the person doesn't feel better right away. So they feel like it doesn't work. So that's why other ways of therapy are used, not antidepressants.
It does increase their activity, but it doesn't mean that the
way of
mood
thinking
is going to increase.
Yeah. Okay.
Or improve. And so when you have this person with more energy, you want to make sure they're using that energy in ways that are adaptive. And so that's why it's good to combine antidepressant medication with psychotherapy. And especially in this kind of first month or so. But as you said, yeah, it takes a while to start working anyway. Another biomedical treatment is neurostimulation. If you apply an electric field or a magnetic field to somebody's brain, it kind of scrambles stuff. And so neurostimulation therapies will apply a strong or mild electricity or magnetic energy to the skull's surface, or sometimes they'll have more invasive techniques to apply it directly to neurons. And if you scramble things, right, then that can inhibit an area of the brain from working. Electroconvulsive therapy is something that you might have seen in One Flew Over the Cuckoo's Nest. And that one, a strong current is applied, and that actually triggers a seizure. And it looks pretty violent. It does seem to work, though, for people with really severe depression. There was a slide back, I think I've already gone over it, that looked at brain activation in a person with depression, and there's less activation on the left side. There's some lateralization in the way that the brain perceives emotions. And so the left side is more about the positive emotions, including anger, and the right side is more about the negative emotions. And one of the ways they discovered this was apparently you can do electroconvulsive therapy on one side or the other. And when they did this, they noticed that when they knocked out people's right side, then they were like elated and euphoric and really happy. And when they knocked out the left side, people were miserable. So that is not considered a first line of therapy, but it is one that is sometimes still used. Psychosurgery refers to removing or destroying brain tissue in an effort to change behavior. And it is risky, it's irreversible, it's kind of your last thing that you do. And you as a psychologist could not do this, right? This would have to be doctors and psychiatrists and surgeons who make this kind of decision. At one time, there was great hope for lobotomy. And that was the idea that you could manage somebody's emotions by severing the limbic system from the higher brain centers. It really didn't go so well. And they didn't realize that for quite a while, because the researchers believed in it so passionately that they wanted to believe that these people were better, right? Whose behavior became, well, it might have become non-functional. Another kind of psychosurgery was done more often in the past is cutting the corpus callosum in people who had severe seizures to create split brain patients. But now we have a better and better medication to replace these more invasive and less reversible techniques. One of the safest, and really most really effective form of biomedical therapy is lifestyle change. Your diet has a lot to do with your well-being. Are you eating enough? Are you eating nutritiously enough? Are you eating often enough? Are you sleeping enough? Sleep is a strong predictor of depression, and sleep deprivation is a strong predictor of depression. And then exercise releases endorphins, reduces stress, reduces depression, makes people feel good. In fact, there are some clinicians that first want to do a lifestyle check with people. Because if somebody comes to see you and they seem depressed and miserable and everything's wrong, and the issue is that they're eating poorly, and they're not sleeping enough, it doesn't matter what kind of talk therapy you use. None of it's going to work. And it makes sense to have a good foundation if you want to have a mentally healthy life. You do that on a strong foundation of having good sleep habits, of exercising regularly, and of eating well. Otherwise, you can't really build on that. On to the psychological model of mental illness. The psychological model comes to us from the study of hysteria. What's hysteria? Being hysterical. The ancient Greeks believed that women were emotional because the hysterium, it's the uterus in Latin, I guess, was wandering around. That's why women are crazy. And so what they would do is they would use herbs, things with like strong scents, and maybe the woman smelled the herb, it would like drive the uterus down. Maybe if it was applied to the sort of vulva down there, then it would chase it up, and you could get the uterus back where it's supposed to be. Kind of a lot of misogyny in the idea of hysteria. Okay. Women actually do have more unstable moods on average than men, and they were just trying to understand why. Okay. That is Jean-Martin Charcot. He was a French neurologist, and he studied this phenomena of hysteria in women. Because women kind of maybe can't cope and they faint, right? And all that sort of thing, and they just lose it. And we have all these like medical students come out and study these demonstrations. So what he did was he would hypnotize female patients, and this provoked the hysterical fits. Okay, but this is hypnosis. So when you're under hypnosis, you do what the hypnotist expects, and he's the hypnotist. Okay, so he's getting them to do this. And if that was a legitimate phenomenon, then we'd still have it today, and we don't. Okay. He had 4 favorite patients who gave the best displays. But people believed that it was like a thing. This is Sigmund Freud's consulting room, the couch that his patients laid on. You can see there's that picture right up there, the one we just saw with Charcot. So if we know that mental illnesses like hysteria are in someone's head, okay, or perhaps really in the psychologist's head, well, that would lead us to the need for psychological treatment, where you're getting in their head and trying to sort things out. And that is loosely called psychotherapy. Okay, the psychotherapist gets in your head and analyzes the workings of your mind. And Freud's view was that this dysfunctional behavior was caused by some kind of an unconscious conflict, probably something about your sex drive, okay, or how you were toilet trained. And you need to resolve that conflict in order to be able to move on. But the dysfunctional behavior is a manifestation of that conflict. Now, let's look at depression through a psychological lens. Well, depressed people have certain ways of thinking. They might make negative evaluations. They tend to do that for themselves. I'm a terrible person, I'm no good. For other people, and the world in general. Okay. And there's also a phenomenon called learned helplessness that was first studied in dogs. a researcher who was studying operant conditioning had taught dogs that they could push a lever in order to avoid a shock. And he had those dogs connected to what he called yoked pairs. And so when the lever pressing dog gets the shock, so does the yoked pair. But the yoked pair dog doesn't, in some other cage, doesn't know what's going on. From that dog's perspective, he's getting like randomly shocked. And what he then did in the next study is he tried to train the dogs to jump over a hurdle in order to escape a shock. And the lever pressing dogs learned to do that task really easily. But the other dogs, their yoked pair, just lay down and gave up and got shocked. They couldn't learn the task. And Martin Seligman called that learned helplessness. And so that could be a part of depression in people. Maybe you learn somehow that whatever you do, it doesn't matter, you still seem to fail. So why try anything? You might wonder, is there any adaptive value to depression? It's possible. Okay. First of all, you don't know what's causing. When we say somebody has depression, there's so many different things that could cause that. Somebody could have depression because they're underslept. They could have it because of the way they're thinking. They could have it because of some issue with neurotransmitters. Right? There's so many different things that can cause this appearance of low energy, okay, and negative affect. So, when we wonder about the adaptive value of depression, we don't necessarily know why that person is depressed. If the person is depressed because they're having sad thoughts, and those thoughts are actually right, there could be some adaptive value there in the ability to identify problems. People with depression seem to have some skill in thinking about complex problems. If you're good at ruminating. People with depression are more accurate than normal people in some appraisals. That's because normal people have a lot of self-serving biases. They might overestimate themselves and overestimate what other people think about them. So the depressed person might actually have a more accurate appraisal. People who engage in the kind of cognitive style that's associated with depression can get caught in a bit of a spiral. So let's say that you have a bad experience, then you explain it in a way that's, say, self-defeating. Maybe you make a global negative attribution about yourself or others or the world. Well, that's going to make you feel pretty miserable. And then what are you going to do? Maybe what you do is something that results in another stressful experience. You then apply your negative explanatory style to get worse and worse. So something that a psychotherapist might do is help people think about things in a different way. So let's say they'll say, I'm never going to get over this. Cognitive psychologists might counter that with a thought like, well, this is hard to take now, but you can get through this. Other people have. You might have a thought like, without my partner, I can't live, can't do anything. Right? Well, you might miss this person, but you also have family and friends. But cognitive psychologists would help address these irrational thoughts that are maladaptive and help people cope more successfully. Depression is a risk factor for suicide. Suicide affects about 1 million people worldwide a year. It's associated with depression and impulsivity, but as you know from Heaven's Gate cult. It's more complicated than that. And there are social reasons why people do that too. For instance, I think in ancient Japan, there was a practice of honor suicide. People who commit suicide because of depression might believe that they are a burden to others and feel a lack of connection to others. It is pretty normal to have suicidal ideation, pretty common. That's different from having a plan. It's just like thinking about suicide is different from having a plan, which is different from acting on the plan, having a suicide attempt. And then that is still different from actually completing a suicide. Most suicide attempts are not completed. They can result in considerable injury, though. Women have more suicide attempts. Men have more completed suicides. And that is because men tend to use more efficient or effective methods. Women are more likely to use less effective methods like, say, poisoning. There's also a phenomenon called non-suicidal self-injury, where people harm themselves without killing themselves. They might cut themselves, burn themselves, hit themselves, like pull out hair, or put things under their nails or their skin to cause pain. If you have overwhelming psychological pain, causing a physical injury can distract yourself from it. So that is one reason why people might do that. If you've ever had a shot like your vaccination, you might find yourself, grabbing your arm, like digging your nails into yourself. That hurts. That leaves a mark. But it's distracting you from the shot, which maybe you feel more uncomfortable with. Maybe you feel more comfortable with the pain that you're causing yourself. But there could be other reasons as well. They might feel guilty, might feel better because they're punishing themselves. Having marks on your arm can also attract empathy and from others. And sometimes we seek connection. There are interesting statistical patterns in suicide. There are national differences in suicide rates. There's been personality studies of people in different populations in different countries. And in some countries, people have higher trait neuroticism. I think they identified the gene that's associated with neuroticism in a Russian sample. But when I read, and I found that article maybe last year saying that 55% of Russian women depressed. Is that because of some genetic reason, or is it because they're living in Russia and obviously they have some issues? There are racial differences as well. I think that white people might be more likely to complete suicide. I'm not sure though. Don't quote me on that. It's not on the test. There are big gender differences. Men are more likely to complete suicide because they use more lethal methods. There are age differences. When we talk about suicide in the media, we usually talk about young people because those cases are very tragic. And when a teenager commits suicide, ostensibly because of bullying, and that leads to the perception that it's more common in young people. It's actually more prevalent in older people who are struggling with a lot of say, health issues. Right? Maybe they feel like they've lived their lives, maybe they've lost a partner, maybe they feel like they're a bit of a burden. Suicide is a leading cause of death in teenagers because they don't die of other things as much, right? There's fewer competitors for death in teenagers. It's really mostly suicide and accidents. There are also some temporal differences. People are more likely to commit suicide in the spring. A little unexpected, isn't it? I can't remember what the day of the week effect is. It's Wednesday. There's a correlation, very strong one. It's like 80% between depression and anxiety, which is interesting because depression is about having really low energy and anxiety is about being all wound up. So what could be going on there? Well, maybe if you're super wound up, then you might go through a low energy period after that. Okay. Anxiety disorders are marked by distressing, persistent anxiety or maladaptive behaviors that reduce anxiety. So a person might seek help because they're very distressed by their anxiety, because they're doing things that are maladaptive because of the anxiety. And a lot of things people do to avoid anxiety are about negative reinforcement. Like avoidance is negatively reinforced. You don't do something that can make you anxious, so you're rewarded by avoiding the anxiety. In generalized anxiety disorder, the person is sort of continually tense and apprehensive and in some state of fight or flight arousal. In panic disorders, people experience these episodes of intense dread. I've had it when I was in withdrawal from an ADD drug. I had panic attacks and I thought I was dying. They were very convincing. Okay. And people can become afraid of when the next panic attack could happen. And they might say, well, I don't want to go out because I have a panic attack in the store. They start spending more and more time at home because that's what's being negatively reinforced. And so people can end up with something called agoraphobia, where they don't want to go out at all. People tend to have phobias, specific fears that would have made sense to our early ancestors. So people might be irrationally afraid of, being alone, being in an enclosed space, certain animals like spiders, snakes, or heights. But there aren't many people that have like a phobia of cars or computers. So we're biologically prepared to fear things that could have made a big life or death difference to our ancestors. In obsessive compulsive disorder, the person has obsessive thoughts. Okay, this is different from obsessive compulsive personality disorder we learned about last class. But in OCD, person has it's an obsessive fear, like I could have germs on my hands. I didn't lock the door. I left the stove on. And then they feel better. They are negatively reinforced when they go check the door. They go wash their hands. And so they'll start washing their hands more and more and more, maybe like 100 times a day, till their skin's coming off. They can't go anywhere, they have to keep checking the door over and over and over again to help, because the compulsion negatively reinforces them by giving them some temporary freedom from the anxious thought. But it's not doesn't work out well in the end. Post-traumatic stress disorder is an interesting one. It's characterized by haunting memories, nightmares, social withdrawal, great fear of something happening again. Maybe can't sleep, hypervigilant. And it has an interesting history. Military veterans had to fight to get this recognized, okay? Because they were just pathologized as cowards. Sexual violence survivors had to fight to have their PTSD recognized, okay? Because they were pathologized too. And the psychiatric rules in the big book of rules are that the traumatic incident has to be life-threatening or sexual. So if you have this set of symptoms, but you were traumatized by emotional abuse, by bullying, by discrimination or harassment, you weren't like sexually assaulted and your life wasn't threatened, then no, sorry, you don't meet that classification. And so even though there's people who have symptomatology like this, they might find that they're not able to get the support that they need. I imagine that PTSD is a bit threatening for the establishment, right? If you have veterans coming with PTSD, well, then you kind of have to do something about it. If there's an issue with sexual violence, well, then what are you going to do about it? If there's an issue with bullying or discrimination, oh no, then the whole system has to look at itself. You want to do that? Easier to say it's easy. Sometimes if we have a psychological issue, we might sort of show up in our body. So some people are anxious and they feel sick to their stomach, have heartburn, and so they experience their feelings physically. And a somatic symptom disorder, there'd be bodily symptoms without sort of physical cause. It's really, say, an emotional cause. There are some folks who are very aware of what's going on in their bodies to the point that they might always be afraid that they have some terrible disease. I have a friend like that, and he's been dying of like so many different kinds of cancers by now. And he's telling me about these other illnesses that he has. And he keeps going on. He had all those disorders, he wouldn't be here anymore. That was formerly known as hypochondriasis. There's a much higher prevalence rate for mood disorders, not including bipolar, in women. And an argument from evolutionary psychology is that women's emotions are not adapted to her, they're adapted to the mother-child dyad. And women have historically done the child raising, and human infants, like even up to teenagers, are quite vulnerable. And so it might be adaptive to be kind of worrying about things all the time and predicting what could go wrong, even if it seems irrational. A friend of a friend lost their 3-year-old daughter. They didn't know why. And on autopsy, they found that she'd stuffed food up her nose. And it'd gone bad. But like, who thinks that anyone's going to do that? Well, maybe the worrying mother has a lot of these kind of thoughts. And there might be some rational basis for that. Sometimes we wonder if people who have mental illnesses are dangerous. Could be unstable. What could they do? They could be violent. Overall, people with mental disorders are more likely to be victims than perpetrators of violence. But there are some cases, some delusional disorders, for instance, can lead people to do something violent. But clinical prediction of violence is quite unreliable. Usually past behavior is the best predictor of future behavior. There are pros and cons to labeling mental illnesses. They give us a common terminology. When I say anxiety, you know what I mean. When I say depression, you know what I mean. We could research it to try to understand it, try to treat it. could, having these terms helps us go and seek support and find information to get a sense of what the course might be like and what treatment might work. Your textbook doesn't say it, but there are economic interests around diagnosing and treating mental illnesses. There's a lot of money involved in diagnosing ADHD. We tend to not talk about that. But then it can also lead to stigma, because then this person is disordered and they're the bad apple and there's something wrong with them and they need to be fixed. And often when we put it all on a person, do that in a way that doesn't understand their social context, dynamics in their social environment. We've talked about psychotherapy and biomedical therapy as approaches to treatment. Most practitioners use an eclectic approach of psychotherapies, different psychological techniques, and cannot really use most biomedical therapies, but could maybe give a referral. Psychodynamic therapy is about understanding what happened in the past, right, that led to current symptoms, trying to develop insight into why you're acting the way you do. And so they might explore past relationship troubles to understand the origins of your current difficulty. Okay, and that helps the patient, notice that terminology, understand how, say, past relationships create themes that they might be acting out in their present relationships. Okay, and that views individuals as responding to unconscious forces and childhood experiences, and it tries to increase self-insight. In a humanistic perspective, there's more of an equal relationship between the therapist and the client. It's less of a kind of doctor-patient style relationship. So that have more client-centered, more person-centered therapies. And it's a bit more growth-focused, see people as having the resources for growth. And it might try to help people grow in self-awareness and self-acceptance. So there's more of a future focus, and the practitioner might be involved in actively listening to the person and providing them with a sense of unconditional positive regard and trying to help foster growth by modeling genuineness, empathy, acceptance. The behaviorists have their therapies too. Exposure therapy is the idea that if someone's afraid of something, just throw them into it. You're afraid of spiders? Here's a tarantula down your shirt. They'll freak out and then you'll get over it. Okay. They really use what's called flooding. You're more likely to see systematic desensitization. We use classical conditioning techniques where you try to pair spider with relaxation. And you start, say, with the word spider, relax them, get them relaxed to that, and then move up to a picture of a cartoon spider, and then finally work up to the point where maybe they're interacting with a virtual reality spider, and to the point where they could get a spider on their hand. Counter conditioning has been used in conversion therapy, which is not recommended. But imagine if you try to punish somebody for punish a gay person for seeing gay stimuli, get them to associate that with, say, an electric shock. Not recommended. Aversive conditioning is used with alcoholism. There's medication that you can take. Again, a doctor needs to prescribe it to make people violently ill if they touch any alcohol. One way people can learn to avoid it. Operant conditioning is using consequences to drive behavior, so rewarding people for the things that we like and punishing them for the things that we don't like having to do. And one way this comes up as it's these token economies. And psychologists will use this when they have captive populations that have to use their token system, right? And you'll see them in hospitals and in prisons and in schools as well. Cognitive therapies are about changing people's thinking, okay? Teaching them new, more adaptive thinking, identifying irrational thoughts and beliefs. And so let's say somebody is sad, they think nobody likes you. Well, how do you know? How do you know what they think? Is that any of your business? Aren't people free to have their own thoughts and feelings? And why do you need people to like you? Like, so you think everyone should like you? Well, let's test that belief. And what would your life be like if you tried to have everyone like you all the time? And you might realize, if the person can realize that this is an irrational desire. Different types of therapy work for different people. Like I've never liked psychotherapy, but I'm argumentative, and this worked for me. I know it worked for you. Cognitive behavioral therapy combines cognitive and behavioral therapy, what it sounds like. So it tries to change the self-defeating thinking along with changing behavior. So it changes the way people think and act. And it's a leading form of psychotherapy. Dialectical behavior therapy is a type of CBT, but it's focused on high risk, hard to treat clients. Maybe people with suicidal behavior or people with BPD. And it teaches them skills to cope with their unhealthy impulses. And those might include distress tolerance, emotion regulation, mindfulness. And it actually involves individual therapy, group therapy, and even phone coaching for like crises between sessions. So if somebody is in a really bad place, you can't be like, okay, see you in 2 months. So people who are getting DBT may be able to contact their therapist at pretty much any time on a cell phone. And then there would be support groups for the therapists as well. Acceptance and commitment therapy invites people to open up to their unpleasant feelings, right? To learn not to overreact to them, or to avoid situations where they are invoked. So it's about accepting your uncomfortable, negative thoughts and feelings as companions on your journey. And the classic metaphor for ACT is passengers on a bus. You're driving the bus, and your unpleasant thoughts and feelings are passengers on the bus. And you can hear them, but you're the ones that are making the decisions. So they try to develop something called psychological flexibility, which is about your ability to stay in contact with the present moment, here and now, which is the only place where you can do things, while choosing your behavior based on your values, being aware of your unpleasant thoughts and feelings, but not letting them drive you. If you were to do that, if you get all caught up in your anxious thoughts, then you're becoming cognitively fused from them. And I actually want you to be cognitively diffused, to be able to step back from them. Compared to DBT, this is for clients who are pretty functional. Their emotions and their thoughts and feelings aren't monsters. When we see people as individuals, we forget that they come in social contexts, most importantly, families. And when a child is acting out, there's often, say, a dysfunctional family dynamic behind that. And a therapist would help people understand their ways of relating to each other and how those can cause issues. And they focus on changing the relational dynamics. Sometimes people get therapy in a group setting. It can be a lot more cost effective. Okay? It saves time and money, and people can help each other. Everyone tells their story, connects with their experience, and gives each other feedback. Quite nice. Need to be aware of iatrogenic effects, harmful effects. Let's say you get a group of people with eating disorders together in a group setting. You have to be mindful that they don't say things that sort of encourage more of that kind of behavior. So there's concern about that kind of thing happening. There are self-help groups out there for almost any problem, like support groups that meet regularly. And nowadays, there are even ones that are online and they address specific problems. And what's nice about them is they give people community, which is a really important part of well-being. And often the people there have a grassroots understanding of the issue. So Alcoholics Anonymous seems to be as effective as conventional treatment for alcoholism. And it was developed by people with the condition. So they know a lot about it. You might wonder, well, how do you know if a treatment works? There are studies on this because you're always going to find positive testimonials from like therapists. They'll say, yeah, therapy definitely works. Then what about people who pay lots of money to get therapy? Maybe there's a placebo effect. So, and maybe they're motivated to say, yes, all these sessions were definitely worth it. What does research say? Well, most people who don't go see a psychologist tend to get better on their own anyway. Okay. So this is a study for people who got psychotherapy, and it shows that both people who got psychotherapy and people who were untreated improved. Okay, but it looks like the average psychotherapy patient can improve a little faster. Like maybe you avoid relapse. However, there's an issue with when we look at studies of psychotherapy. Right off the bat, that problem is called the file draw problem. And it's that scientists are more likely to publish their positive results than their null results. So if all these studies are saying that it works, well, what if we only publish the studies that say it works? Okay. Research has not found any effect of therapist experience, training, supervision, registration, or licensing on the benefits of psychotherapy. Psychotherapy is regularly provided by paraprofessionals. Sure, there's many times in your life where you have been counseled by a teacher, right? Or counseled by a boss, or counseled by a nurse. And when I think of my biggest struggles in my life, like my friends counseled me through those things. Okay, we're not registered psychologists. So that's a bit of an ego check for us psychologists. When you think that like the going rate is something like $250 an hour, maybe you could get it from a friend. But a risk of talking to a friend is that they might go and gossip about it. One thing to keep in mind is that people aren't necessarily ready to change. Like, let's say this is the readiness to change model from health psychology. So consider that, let's say somebody is smoking and their doctor is telling them they need to quit smoking. If somebody is red light and they actually don't want to change, you're not going to achieve anything by trying to push them into it. It could actually damage the relationship and maybe they won't come back. So in these circumstances, the therapist will just try to keep the conversation going and take the expectation of change off the table and keep talking to them until they get to a yellow light kind of place where maybe they're ambivalent about changing. Or maybe they could think about quitting smoking. They don't really know if they want to, or maybe they don't want to. And at that point, the therapist would try to find personally meaningful reasons for change that align with their values. Okay, this person loves their grandkids. Well, if you weren't smoking, you could run around with your grandkids more. And once you get to the person, to the place where they're green light, where they're ready to change, then it's appropriate to go ahead with these strategies to change the behavior, like setting SMART goals. It wouldn't make sense to do that to somebody that doesn't really want to change. Studies on successful psychotherapy suggest that there's 3 things that are important. And interestingly, they're not the type of therapy the person's doing, like whether it's cognitive or whether it's psychodynamic. What seems to matter is that the therapist is caring, show empathy, like that they're providing new perspectives and giving hope. And a lot of psychologists can do that in different ways. A lot of other people can do that outside of professional psychology. It's important to know that treatments can actually hurt. Like sometimes you go see a provider and things get worse. That can happen too. So treatments that actually cause harm are iatrogenic. A classic example is the drug abuse and resistance education program, where police officers go into schools and tell kids that drugs are really bad, and they show them all these different kinds of drugs and how to use them, and tell them about the terrible things that happen, and it just doesn't seem to reduce kids' chances of using these. So important to remember that therapies can be iatrogenic. And let's say that a therapy just doesn't work, just doesn't make any difference. When you spend all this time and money on it, you actually should have spent on something else. So the ideal clinical decision-making does depend on good research evidence. But you also want to take the client's culture and values into account and combine that with your clinical judgment in terms of deciding on a course of action. Your textbook ends with a section on resilience, and they're expressing hope about mental health programs that work to build resilience. I like that idea they have there, that many disorders could be prevented by changing oppressive, esteem-destroying environments into better ones. Oh, that's about the environment and things that community psychologists are doing. And that stands in distinction to their definition of resilience, which is about like a personal strength that helps people cope with stress and recover from adversity and trauma. I don't really agree with that definition. See resilience, a better definition of resilience is that showing a successful outcome in spite of disabling circumstances, right? But in spite of those hostile environments. And you could ask whether it's fair or ethical to expect resilience. And maybe the better thing to do is to focus on the systems that are causing the issues. I think that this idea of coping is better represented as adaptability, which is something you can actually measure at the population level. Technically, you can't measure resilience at a population level because you predicted that these people would fail because of their terrible environments, and they didn't, so they're resilient. So it's really about error in a model. How do you measure that if it's about being wrong? Easier to measure adaptability. You already know what that is. If you go and look at your textbooks, risk factors and protective factors for mental illness, you can see that a lot about these are about having, say, depleted resources, like low socioeconomic status, like being in pain, having stressful life events. And they're also about maladaptive responding, like having poor work skills and habits, social incompetence. Substance use is about misusing resource. If you look at the protective factor, they're about having good resources, like community, empowering community, having opportunities, right? Knowing what your skills are, having a lot of social support. And those protective factors are also about adaptive responding, right? About problem solving skills and resilient, good coping with stress and activity. That's about what you do. Having social and work skills. And so I'll bring you back to this, close up the course on this idea of adaptability. If you know what your resources are and you use them to respond in ways that are adaptive, get good results. Well, those good results will go and buffer your resources, and you learn better and better skills. And so you can get in an upward spiral. The negative version of that is that you have depleted resources, you misuse them, you don't know what they are, how to find them. Maybe even if you have resources, you engage in maladaptive responding. That'll end in bad resources that'll further damage your resources. In practice, doing something maladaptively, maybe you'll get better at doing it maladaptively. And so you find people in kind of caught in negative spirals. All right. Thank you all very much for your attention. The last deliverable is the week 13 quiz. I need to revise that, and I will email you guys when that is ready. I plan to have the final grades posted by the end of the day on April 14th. I'm still grading some assignments, so if you email me, you might be waiting for a response. And would you please join me in giving you a big round of applause for a job well done. Going forward in psychology, your advisor is Robin McIntyre, and you're welcome to reach out to me or by email or connect on LinkedIn. And I wish you all a good summer.
Thank you.
Thanks.